Hello, this is a case presentation of Leflunomide hepatotoxicity in a patient with psoriatic arthritis. This case is unique because although leflunomide carries a black box warning for hepatotoxicity, we are presenting a case of a patient on a low dose of leflunomide who developed hepatotoxicity with subtherapeutic serum levels. Leflunomide is a disease-modifying anti-rheumatic drug that is only indicated for use in rheumatoid and psoriatic arthritis. It is typically dosed at 10 to 20 milligrams orally per day, in which most patients are on the 20 milligram dose, but our patient was on a 10 milligram dose. So our case begins with a 58-year-old African American male with a past medical history of psoriatic arthritis, gout, chronic kidney disease stage 3B, type 2 diabetes, hypertension, and paroxysmal atrial fibrillation, who presented to the emergency room from a nursing home. This patient was hospitalized 3 times in 2 different hospitals and spent a total of approximately 3 months in the hospital. The most significant hospitalization is the second one, in which the hepatic injury was first noted and fully worked up. It was on this hospitalization that the patient's liver function tests and bilirubin began to raise. 5 days after admission, the patient's ALT was 51, AST was 88, and total bilirubin was 1.8. And the levels continued to increase during their admission. The workup included a viral hepatitis panel, HIV testing, and a thorough autoimmune panel. All testing was negative except for an anti-smooth muscle antibody that was positive at 112. Further workup included 2 liver ultrasounds, the first one showing hepatic steatosis and the second one showing hepatomegaly, and a CT abdomen and pelvis with and without contrast that didn't show any hepatic significance but did show lymphadenopathy. A liver biopsy and lymph node biopsy were both performed. The liver biopsy showed acute lobular hepatitis and moderate interface hepatitis with increased eosinophils. The radiologist commented that they believe, given the increased eosinophils, that the hepatic injury could be due to either an infectious etiology or a drug-induced hepatic injury. But autoimmune hepatitis could not be ruled out. And the lymph node biopsy was negative for malignancy, and as was the flow cytometry. The third hospitalization is where we found the culprit of the hepatotoxicity. It was on this admission that the patient actually developed urosepsis with ESBL and MRSA. They required ICU admission. But after the ICU admission, when they were brought back to the floor, the patient still had liver dysfunction, elevated LFTs, and no one had yet commented on what the proposed etiology of it was. There was no further workup done after the workup at the second hospitalization, aside from an MRI, MRCP that was done that showed similar findings to the 2 liver ultrasounds that were done at the previous hospitalization. It was then that we consulted rheumatology for further evaluation. They looked into the patient's history and found in the nursing home records that the patient had been on leflunomide 10 milligrams daily. This medication had not been started during this hospitalization, nor do we believe it was listed as a medication during the patient's prior hospitalization. Drug elimination was started with cholecystyrene, 8 grams 3 times a day for 11 days, and the effects of this washout were significant in reducing the liver function tests and other elevated values. Cholecystyrene is used because leflunomide exhibits a enterohepatic recirculation pattern that cholecystyrene is able to inhibit.